case-based discussion number 2.
Hi, Paul. Laura here in Melbourne. I'm happy to jump in.
Oh, lovely. Thank you. Pleased to meet you, Laura.
Nice to meet you.
Now, so what we've got here, we've got a pretty common presentation. We've got a 32-year-old patient, and she's got gastrointestinal symptoms, and they appear to be postprandial. So what are your first thoughts? What jumps into your head about this to start with?
So my initial thoughts are just from the alternating diarrhea and constipation is a possible presentation of mixed IBS. Was my very like that was the first thing that stood out to me.
Absolutely. Absolutely. I mean, it's textbook. It's textbook. And almost certainly it is. And we'll get into that and management for that. But is there anything that, even though this is probably that, should we exclude anything?
Yeah, 100%. So 32, like quite young still. So the key is you do want to rule out IBD. So doing initial bloods and in particular a fecal calprotectin is quite sensitive for IBD and inflammation in the gut. And also
Let's just say, first of all, textbook straight up. That's exactly how I would approach it. But let's dig down into these tests. I think we need to, when we're ordering tests, it's useful to understand what we're actually looking at. Fecal calprotectin, beautiful. So this is a measure of neutrophilic activity in the gut. Now, not all inflammatory bowel disease is neutrophilic. We've got, for example, eosinophilic esophagitis, we've got lymphocytic colitis, so on and so forth. So it is, while it is very good, and it is probably one of the most sensitive tests for inflammatory bowel disease, it's also useful to understand that there's potentially other types of inflammation within the gastrointestinal tract that fecal calprotectin won't pick up because it is a neutrophilic-based test. But anyway, sorry, carry on.
Oh no, yeah, so I suppose like to help with that, like the level would be important. So greater than 150, I think it's nanograms from memory is the
Yeah, well, let's assume that, okay, you're doing some excellent tests there. You're probably also doing a celiac serology. You're probably also doing nutrient levels because you want to make sure people with inflammatory bowel disease tend to have impaired absorption of nutrients. And we'll come back and talk about that in a moment. But clinically, in somebody's presentation, we know that inflammatory bowel disease is frequently associated with what we call the seronegative spondyloarthropathies, and you probably should all know the 4 subtypes of those at the moment. But there's so much overlap between them. I actually don't find the clinical distinction or distinguishing between those 4 groups particularly useful. But I know that people with joint pain, inflammatory joint pain, migratory joint pain that's worth in the morning or after periods of immobility, frequently will have these inflammatory gut-related issues. So can you give me just clinically a few kind of things that you might look for on a physical examination or a history to screen for, inflammatory bowel or the associated seronegative spondyloarthropathy?
Yep. So inflammatory bowel on its own, the things I'd want to ask for is blood in the poo as well as mucus. I'd want to ask in terms of family history, as you said, ankylosing spondylitis, psoriatic arthritis, enteropathic or reactive arthritis, and you'd also want to know, is there a family history of HLA-B27 positivity, or have they had that in the past? In terms of musculoskeletal manifestations, you want to ask for, in particular, buttock pain or alternating buttock pain. You also want to ask about enthocele and the enthesopathies such as Achilles issues.
Yeah, let's talk that is a huge one. That is absolutely huge. So in my screen, I don't always ask because sometimes people just accept things as normal. You press on each of the bony prominences, the epicondyles around the elbow, the back of the calcaneus, and the plantar fascia insertion. By the way, plantar fasciopathy almost certainly is an autoimmune enthesopathy, which is probably why there's so many treatments being described for it that are largely completely ineffectual, and why when you inject them with steroid, they'll get a temporary, but they will get a definite relief for a period of time, because it's the immune system is doing a lot of the damage. So if we suppress the immune system with a corticosteroid, you will get some benefit. So, those kind of things. Do they get mouth ulcers? That's very common in Crohn's disease, and everything else. So, I mean, you're hitting this one out of the park. So, okay, so let's say that they do have, you've done some blood tests and the vitamin B12 comes back. And the vitamin B12, the reference interval is 135 to 650, because you've done a lot of them, you memorized it. And their level is 250. What do you think of that level of vitamin B12?
That obviously it's a very elevated value.
Okay, so the reference range is 135 to 650. So
to 650. Sorry,
they're about 200. So the point I'm making is the reference intervals don't reflect good health or optimal health. And we've got clear literature that anything less than 400 in serum B12 is suboptimal for health. And a lot of blood companies now, they'll have a little blurb, a paragraph below the vitamin B12 that says, if it's less than 400, you should consider it to be low or equivocal. Well, we know this. So don't always trust reference intervals when you're doing a blood test. That, if you've got a 95% confidence interval, you exclude the top 2.5%, the bottom 2.5%, and you're assuming that everybody else in the middle is optimally healthy, and that is simply not the case. We also see this with iron. I mean, as you guys see people all the time with a ferritin of maybe, 35 or 20. And sometimes now the lower end for females is set at 15, and they feel tired. They feel terrible. They're depressed because you may not know, but iron is a necessary cofactor for the synthesis of the catecholaminergic neurotransmitters like dopamine and serotonin. So we also know it's important for mitochondrial function. So we've got randomized controlled trials that show when you infuse females who are deficient in iron with iron, they actually lose weight because their mitochondrial function improves, their mood improves. So do not always trust the reference intervals when you're doing a blood test. I think that's a very critical point, and don't be afraid to do your own research. And by the way, if anybody ever wants to reach out to me and talk about this after the tutorial, because I know we're only touching on things, I'm really just trying to give you a taster give you visibility of what you need to learn about and where you need to direct your learning moving forward. I'm very happy to have conversations. All right, so let's assume that you've excluded inflammatory bowel disease. You clearly know your stuff. You're doing good blood tests. You do an excellent physical examination, and you diagnose irritable bowel syndrome. How do you manage this?
So one of the interesting things about in irritable bowel syndrome is that we actually still don't know the definitive cause for it. We have hypotheses about what the cause is, and so we direct management at possible.
Is there any evidence-based treatments? Is there, putting aside the limited understanding about the underlying pathophysiology, which I won't give you my idea on, but is there any proven treatments that have been shown on average to help patients?
Yeah, so gut hypnotherapy to reduce the neural sensitivity of the gut, so gut hypnotherapy and CBT. So there's the Nerva app, which can be quite helpful. There's also, you can do a low FODMAP diet in terms of restriction for 6 weeks, and then a gradual introduction with trying to find what the main triggers are for patients, keeping in mind that evidence does show that the FODMAP foods themselves are not from memory, it's got to do with like the gaseous production from the FODMAP foods are the same in people with IBS and not IBS, but theoretically it improves symptoms because of, again, the neural sensitivity element of it.
Well, I guess not just theoretical. The patients tend to feel better. So, and given that you're very possible, I had questions on FODMAPs on my exam from memory. I have nothing to do with writing the exam, by the way. Given that this could be an examinable topic, it's probably useful for you to know a little bit about FODMAPs. Do you know what it stands for? You don't have to cite it all off, but what do the letters represent?
I think it's like oligomonosaccharides, and
they represent things that are not digested very well. So it stands for fermentable oligodimonosaccharides and polyols. But you don't have to know. I mean, actually, on one, I believe you might actually have to know what they stand for. But understand that these are things that are not digested very well. And if your body doesn't digest it or absorb it very well, your bacteria can have a field day. So what do the bacteria do, your microbiome? What do they do if they come in contact with, say, a fructose that you haven't digested?
So I believe it produces, it ends up producing more gas as the time
Exactly.
it's fermenting.
It ferments it and it produces gas. So if you've ever got anybody who's complaining of prominent bloating, well, that's really suggesting of microbial fermentation. Now, you can also have an osmotic effect, which is where you'll draw fluid into the feces. So that can explain why you'll get a bit of bloating. And you might also have loose stools. Now, depending on if you've got a methanogen producing bacteria, we know that methane actually inhibits peristalsis. So you can have loose stools and constipation at the same time, which seems quite paradoxical. But when we actually look at the science and understand the role of the methanogen producing bacteria, that's quite plausible. So understand that FODMAPs is a real thing, and a lot of people do significantly improve their symptoms when they do eliminate FODMAPs. And also understand that the P stands for polyols, which can be seen in artificial sweeteners. So people on low carbohydrate diets, if they're having, sugar-free chewing gum, you look on the back of those packets, they say warning excess consumption may have a laxative effect, and that's why a lot of people on low carbohydrate diets, they're trying to fix their their sugar problem, and they're having a lot of cauliflower mash. Well, there's a lot of indigestible foodstuffs in some of those foods that will lead to a lot of bloating. But look, we might move on in the interest of time, but essentially I'm very comfortable. I'm very happy with that answer. You seem to have a good grasp of what its different pathologies and solid investigation pathways.